I think we're going to get started here. And folks who are in the room here, please help yourself to food if you haven't done so already. Maybe if we can do roll call, just for posterity purposes and making sure everyone knows who's on board. Let's start with people in the room here, and then we'll go to the video and the phone. Julie, or maybe we'll start with Cheryl, because Julie's going to food in her mouth. Cheryl, you want to kick it off?
Cheryl Vichala from Arab Blue Cross.
Scott Kennedy, Olympic Medical Center.
Lawyer Martha Shea, Legacy.
John Scott, UW-Madison.
Roddy DeChintel, Cambria Health Solutions.
Francis Goff, Unit Healthcare.
Cartel, UW. Sheila Greenchuk, Washington State Health Information Management Association.
Julie Stroud will take your calls.
And then on the video, we've got Dr. Jones.
Hey, Jeff Jones, family physician in Newport, Washington.
Good. And Dr. Jimenez.
Ricardo Jimenez, family physician in Seymour Community Health Centers.
Great, thanks for joining. And people on the phone, if you can please introduce yourself. Is there anyone on the... Yeah, go ahead.
I'm not sure if you heard me. It's Randy Becker from Eatonville.
Hi, Senator Becker. Thanks for joining. Anyone else on the phone?
Sean Graham with the Washington State Medical Association.
Hi, Sean. Looks like we maybe get some other people who just joined. Anyone on the phone who wants to say hello?
Hi, this is Bonnie Burlingham and Kathy Schmidt from the Washington Department of Health.
Great, thanks for joining. Anyone else on the phone? Okay, well, great. I'm going to pull up our agenda for today so folks can follow along. The first thing I wanted to do is go over the charter that we were talking about last time. And that document was circulated by email. So I wanted to have a little bit more discussion and see if people had any further clarifications or comments on that. And let me pull up that document. So let's see here. There it is. So I'm going to read the vision statement. So the vision of the collaborative is to advance excellence and innovation in telehealth for all Washington communities, improving access to high quality, safe, and affordable healthcare in Washington State. I think we spent quite a bit of time on that vision statement. It's pretty tight. I like having one sentence. Any things that people wanted to exclude, include? Okay. So hearing no other comments about that, maybe we'll move down to the mission statement and then talk about the goals. So the mission statement, I'm going to read it for folks. The Washington State Telehealth Collaborative will provide a forum to improve the health of Washington residents through the collaboration and sharing of knowledge and health resources statewide and increasing public awareness of telehealth as delivery mechanism. The collaborative seeks to enable development and delivery of technology-assisted programs that promote access, sustainability, utilization, and affordability of telehealth services. Any comments? Very good. Okay, good. Now the goals, some of these are directly lifted from the legislation. Including, I think, the last three here. So I would, unless people feel very strongly about these last three, I think we need to kind of keep our eye on the ball and make sure that we're getting the deliverables as required by the legislation. So I'm just going to read those last three, and unless people feel really strongly, I'd really like to keep those last three. So the first is develop recommendations on improving reimbursement and access to services, including origination site restrictions, provider-to-provider consultative models and technologies and models of care not currently reimbursed. The second that's specified in Senate Bill 6519 is to identify the existence of guidelines, billing requirements, and fraud prevention developed by recognized medical and telemedicine organizations. And the third aspect of the legislation was to make recommendations regarding development of technical assistance center to provide implementing or expanding services. So those were the things that were straight from the legislation. And there are two others that we had talked about last time. The first is to improve access to telehealth education and resources for both providers. And secondly, to enhance the adoption of evidence-based telehealth through a positive patient and provider experience and reliable technology.
I had a question about the third one, so the first one that you read.
Yeah.
Was there a clarification of what reimbursement meant? Was that more coverage related, or was that actually rates? Or
I don't know. I mean, this is lifted straight from the legislation.
sure.
So, Senator Becker, maybe I can ask you. The question before the group is this little bit about developing recommendations on improving reimbursement. Is that about coverage, or is it the actual more technical aspects of it? Is that basically your question, Brody? Yeah.
Okay, well, I think from my perspective, I was looking at it more of the, improving reimbursement so that physicians and providers actually got paid for services. But I'd like to keep it broad enough that we look at the whole picture as long as we fall in that parameter. But I'm open to looking at everything with that. Could you hear me?
Yeah. No, we're all just kind of nodding in agreement, I think. Okay.
I had a comment. Hi, Joelle.
Hi.
I just wondered if it might be worth considering how we might optimize integrity of patient health information, and if that's within the scope of this.
Sure. Joel, do you want to join us up here?
Sure.
Okay. So the question from Joel Fati was, is there any interest in this collaborative helping out with IT security and confidentiality? And I think that's probably why we have Sheila on the group. Really look to your expertise. And I'm just wondering, Joelle, if there's anything in here. I mean, I think maybe fraud prevention.
And I didn't know if that was more directed towards insurance and people perhaps representing themselves or portraying themselves as legitimate healthcare providers or healthcare delivery systems that are engaging in delivery of services that may not be above board versus.
And I'm just wondering if this little bit about fraud prevention maybe covers your concern, identifying the existence of guidelines, billing requirements, and fraud prevention.
In terms of patient health information.
Yeah.
Or privacy. And I don't know if there's maybe a formal document for that legislative language that we could review. And the other piece of it is, I think there are so many things on the backside of telehealth, delivery of telehealth services, including encryption of, the audio video conferencing equipment and things that perhaps people don't above board totally understand. Really ideally needs to occur. So do we set standards for that or establish language to make people aware that that's a consideration when you're looking into delivering these types of services?
And I think this is where we could probably fall back on some of the best practices that like ATA's developed. I mean, they do address a lot of that.
The guidelines do address technology and encryption and compliance.
I think just rather than recreating the wheel, maybe we can point people to it. Francis helped develop some of the guidelines.
Yeah, it's also there are guidelines that really cross cover those same general areas in whatever the specific guideline, whether it's urgent care, telemedicine, or teletherapy, or telepath. they all have some element of that does cover what you're correctly bringing up.
I think, though, for one point of clarification, when you're talking about the integrity of the record, we're talking about in the second to the last one, identify the existence of guidelines. Wondering if we might want to add clinical documentation and billing requirements, because the clinical documentation is what's going to support what's ever billed for those services.
How about
So that I don't know if that addresses what you were asking as far as the clinical documentation for the integrity of the record.
Well, the documentation also legitimizes, a visit, right?
Right.
How about I add clinical documentation and billing requirements? Okay. So
You want PHI compliance in there before fraud? Is that overstating it?
I mean, if it's inferred based on well-established guidelines and information.
yeah, I
Well,
think
they are, but to your point, it may not be really clear. People may not know what's in what we're referring to. So calling it out where this is coming up is a concern if we have it, others will have it as well.
Yeah.
So to the point where we can clarify without making it too broad. I think the documentation is great because you're right, that's tied. We just don't have anything specific to privacy, don't we, fraud.
So in the last sentence, you might consider adding about making recommendations regarding development of privacy and security technical assistance or something like that, because that way you would address both the privacy as well as the security that you want to make sure that's in place for the technical component.
So this is Senator Becker. So I like hearing what I'm hearing, but the one thing, and maybe I'm missing it as I'm trying to go through all of the documents here, is I think we need to be talking about addressing malpractice, what in telemedicine may differ in creating a malpractice lawsuit versus and person to person. So when we're talking about fraud, I think we also should talk about liabilities.
Okay. So Senator Becker, I'm going to add to our fourth goal. It reads now, identify the existence of guidelines, clinical documentation, and billing requirements. Should say malpractice prevention or malpractice.
You can be as uncommittal as saying to address the areas of liabilities. Liabilities.
Liability prevention. There. Okay. Liability and fraud prevention.
Yeah.
Right, there we go. All right.
And you could be more medical malpractice and fraud prevention.
Yeah,
like
that's what I'm writing.
Yeah.
Right now it reads liability and fraud prevention.
Okay.
Okay. Quite a bit of work. So I don't think we need to do all this before our report in December. This will be ongoing. It would be great to knock some of these off our to-do list. Anything else on our goals we want to accomplish?
Do you want anything on injury visibility? Ability for different systems to become more and more interfunctional.
I think that's a good question, Scott. And I think maybe the phrase in the second point there, reliable technology, addresses that. And maybe even when we look up here.
The interusability is a huge,
yeah.
huge deal. So I would.
Yeah.
I apologize. My computer's having problems here. So.
maybe even after the second sentence, and reliable technology with interoperability. I think one thing that came up in my mind when I was reviewing, I was unable to attend in August, but the notion that there are outlying areas that don't even have web access or broadband access, and how do we support those centers to get the minimum required equipment, and is that something that we have an obligation to address? If we're really in it to address health disparities, and that's sort of the crux. Like, if we don't have the equipment and the interoperability, then it's an issue.
Yeah. I think that starts to get into more of a technical assistance center. We're doing an audit and things like that. And I think I would make a recommendation if that's what we're hoping to do, that we just need to scale up a little bit more. That's a pretty big ask to do a statewide audit. I don't know what other people think. Sheila, I mean, you kind of know the IT connectivity in the local area. I don't know, if you have a sense for some of these more outlying communities with broadband access.
Well, and I think that issue came up at the last meeting, talking about rural areas, and that's a huge challenge. So I don't know the answer to that, other than you're going to have to be doing some type of evaluation and trying to determine what technology solutions are even available to them, depending on where their location is.
Was part of the technical assistance vision readiness assessment?
I think so. I mean, that would be readiness assessment. Yeah, any other comments on the goals? Got a number here. I'll tell you what I'm going to do. I'm going to save this, and I'm going to send it around and ask for a final vote on approval for this by email, so that everyone can vote, even people who are not in attendance. And then maybe we just move on to our next agenda item. That's okay. So the next thing I want to do is just make sure there weren't any remaining comments from the August minutes. Any other clarifications? Someone had sent me an email just to clarify August minutes. Give you a minute or two to review that. Any addendums, edits? This will be part of the public record that we'll release. So I just want to make sure that there's not anything that's sensitive that the public wouldn't be concerned with reading. So unless I hear anything, I'll assume that the minutes are approved from August. Great. So I just want to give you some brief updates on things that we had talked about. I think there was some interest in looking at how telemedicine can interact with the statewide emergency preparedness system. And that was something that Sue Stern and I had looked into, and let you know that there is an ATA, there used to be an ATA subcommittee on this, and there was a special interest group, and I've reached out to David Balch, B-A-L-C-H, and have a call set up with them later this week, kind of learn about what they were doing and how we as a state could incorporate telemedicine. And there's also a statewide emergency preparedness group, and I'm set to speak to them along with Sue Stern in the next month or so. So they're very interested. We've already had that initial outreach to them. They're very interested in kind of understanding a little bit more about telemedicine. But right now, as it sits, there is no integration of telemedicine to any kind of emergency preparedness in our state. Absolutely not. So, and part of the challenge, just folks who are interested, is the emergency preparedness often is planned on the county level. So there's a King County, Pierce County group that meets regularly, but there's not per se a true statewide ongoing maintenance on a county basis. Also, I wanted to give you an update on the website. We're trying to have our minutes, kind of a resource center, and notices about public meetings on a website. We've talked about various places where this might be hosted, and based on availability and expertise and things like that, we're hoping to host this on WISHA's servers, so the Washington State Hospital Association. I wanted to see if there's any concerns or questions about using WISHA for that purpose. They have offered their web IT technical expertise for that. It doesn't have to be necessarily underneath all of their main website. It would be a standalone, but it would be hosted on their servers, and their technicians would be supporting us. Any concerns or questions about that?
Dr. Scott, for clarification. Yeah. Shirley Whitaker from the Washington State Hospital Association. We actually can't host it as its own standalone site. It will be embedded within our website. We're unable to accommodate that piece, unfortunately.
All right. Any concerns about that?
I would suggest that an advantage of that is we have hospitals from all over the state and many other clinical systems looking at that website, so they enhance awareness of work.
I think it could also be a disadvantage because as we focus more on the ambulatory setting, and although we're integrating a lot of health systems and hospital systems, not all are, and it may not be the most commonly thought of place to go look for this information.
There might be ways to around that to link, like something on the WSMA website. Sean, I don't know if that's possible, or if you'd be interested in doing that. Or our own individual websites, we could make that link. That's the thing about the web is once it's hosted somewhere securely and it's updated. The main thing is about any kind of web content is that it gets updated. So I hear what you're saying, but there are other ways around that for linking.
But ideally, it'd be great if it was its own website and destination. I mean, as far as if people from other states are trying to look at things and they're Googling whatever, it's just from a search perspective. If it's underneath someone else's website, things kind of get confusing sometimes. They think they're going the wrong destination. So it's just from an ideal perspective. I don't know whether it could have its own URL, but it still bumps over to that piece. Like there's technology options that are around that, but as long as the URL is something that's ideal, unique to this, that would be ideal.
I mean, we looked at hosting it within UW, and we have the same challenge. It would be if I'm not going to rely on my IT people to do it, they have to do it underneath UW, not us. So, and when we looked at Department of Health, and DOH wasn't able to support this. So, and this is kind of like our third option. So I think
I could take it back to, not that I'm offering to host it either, but at least our technology people may have some ideas, at least on what they can do. So.
Well, we haven't started building it, so it's not like it's set in stone, but just kind of wanted to let people know some of the issues we're running into.
I know we kind of explored this on the first meeting, but wherever it lives, is it in a location that's appropriate for both providers and potential patients or the community to access?
I mean, if you look at the New Mexico Telehealth Collaborative, it is a standalone, and it does have both a patient and a provider sections. So I think we can design it that way. It's very clear where a provider should go and where a patient should go.
This is Randy. May I ask a question?
Sure.
On the New Mexico model, I understand it to be a standalone, but is it financed through the dues that are collected, or is it financed through the state or in another methodology to have people doing all the work there?
Yeah, so Senator Becker, great question. And the answer is that it is all the activities are financed by dues. So there's a membership model. So I think that that's the downside of that model.
But is the participation rate in New Mexico of providers, do you know what percentage of providers are participating?
I have to go back and look at the membership, Senator Becker. My recollection is there were not a ton of providers on that committee. It tended to be very heavy on organizations and insurance companies.
I gotcha. Okay.
Yeah.
Thank you.
Yeah, and that is a drawback of what they've set up. I'll tell you what, unless someone has any other kind of better ideas, I think we're going to preliminarily keep going ahead with working with WISHA.
I think to some extent, you got to start somewhere, right? There's nothing to say that if we start there, that 2 years later or a year later, whatever, that we could move it over to its own entity once we have a funding source.
I wanted to add just one little item to our agenda. Cara wanted to tell folks about the NRTRC. Cara, can you let folks know about that?
Yeah. So I sit on the board of the Northwest Regional Telehealth Resource Center, and every year we have a conference which we like to think of as a regional ATA, American Telemedicine Association conference, that serves a 7-state region. And it will be held April 10 through 12, yeah, how many days, in 2017 here in Seattle. And we are currently looking for folks who would like to present about what they're doing with telehealth. And I thought, what a great place to bring that opportunity to all of you folks who are heavily involved in it. So I brought a stack of requests for abstracts, call for abstracts. So if you'd like one, come take it. If you would like me to email, just give me your email address or contact me by email and I'll send you the information. The deadline on here has passed, but we've extended it because we didn't get the quality of abstracts in that we want. So I would encourage you not only to submit an abstract to do a presentation, but also consider attending and sending your staff to attend.
It's a great value for your money. I think it's around $150 is my recollection.
Yeah.
And it's at the Olive 8 downtown Seattle. And they really get some great speakers. There's a Telehealth 101. So for people who are new to telehealth and just kind of looking to get started, that's a great opportunity. And do you know who the plenary speakers are going to be?
Still to be determined.
But
it's usually national, international speakers.
It really has some of the fathers and grandfathers of telemedicine have spoken in the past. So we would encourage people to go to that. It's well worth your time and money. Good. So next thing I wanted to do was turn to this question about the definition of home. And this was called out in Senate Bill 6519. So, and just to reorient folks, in the original telemedicine bill, which was Senate Bill 5175, there were 7 approved originating sites. And those included like a doctor's office, a rural hospital, I think a dialysis center. All these were basically medical facilities, and the one that was really left off of it was home. So in Senate Bill 6519, home as an originating site was added. And I think there was some question at the time of the bill being put forth is what is home? What does home mean? So I wanted to open up that question today, and hopefully we can have some recommendations as to what would be a good definition or an understanding of home. So I'm just going to open it up there and see if people have questions or comments or ideas.
Well, this is Cheryl. So we had to define home for another project we were working on, so I brought that definition. And it's got 7 different places that we consider home. So I just throw those out. One is actually the home. One is a homeless shelter. The third one is prison. The fourth, assisted living. The next one, group home. and then hospice, and then a resident substance abuse treatment facility.
Okay. And of course, their domiciled residents would be another one.
I thought we could use that as a starting point anyway.
Can you read those again? So,
So
homeless shelter.
Prison, assisted living facility, group home, hospice, and then a resident substance abuse treatment facility.
So, no, we have the same question, I think.
Go ahead.
Are we defining home as where the patient is? Is that what this particular?
Yeah, this is where the patient is. Yeah.
And not the provider?
Not provided. This only has to do with where the patient is. I think there was a question on the phone or a comment.
This is Senator Becker. Yes, please. The reason that we asked for the definition is people were saying they did not want people calling in from a parking lot, at Safeway and having everyone around them and trying to actually have a patient encounter with that type of thing. But what I just heard, I want to make sure that the patient can be in their own home or they can be in a home of someone that, they feel safe and secure with. So I don't want to be so descriptive that we eliminate too many areas as well.
Yeah.
I would want to bring up, what is the patient's view of home? Do the patients want to be restricted to, I can't have a video visit while I'm sitting in my own car with the doors closed, windows up, and I'm comfortable in that space? I feel it's privacy enough for me to conduct a medical visit. Like, I don't want to limit ourselves to the definition of you've got to be sitting on your couch in a certain location to have a medical visit. It doesn't quite ring true from the patient perspective.
Yeah, Francis.
Yeah, so just to step back, and I apologize for not being here at part of the meeting last time we were talking about programs. We've had a lot of experience with the virtual urgent care program, and that's what we've just rolled out at the end of June. So that's now statewide for all of our Medicaid members, so free of charge we offer that to them, Apple Health Medicaid. And prior to that, and for a number of years, I've had experience with this, again, patients in their home, what does that really mean? And I think it really speaks to the point of not being so restricted, but home or natural setting. So I've seen it used that way in many documents. The natural setting being a car, the windows rolled out by yourself and, some, private area. It could be a workplace environment, again, door closed, private room, so I think it has to be conducive to where the patient can actually receive care in whatever private environment they can find and are comfortable in. And then I think some of these other definitions may raise other questions about coverage and billing, prison, for example. But again, I think they could be examples of, but I don't think they should be limited to.
Right.
Yeah, I want to clarify what the concern is. I think Senator Becker hit on it was really privacy, and making sure that when patients see us in person, we can assure that there's privacy and security. And so I think what we can say is that we can make some kind of recommendations that this should be in a as private a location and it's quiet, it's conducive to environment. But I think a definition that's a little bit more expansive, so say home or a location that the patient determines as being appropriate. It's a little bit less.
I'm more comfortable if you said patient and provider, because I do think the provider should know that the patient is in a safe place, especially if they're talking mental health issues.
Yeah, we've had I just share an experience where we've had some of our burns patients who are following up and they're on their cell phone, but they're in their car. And we're like, no, you need, that's not okay. You cannot have a televideo visit while you're driving down I-5. So, from a practical perspective, we say no, stop, pull over.
Yeah, so the learning center type setup where you've got REI here, Starbucks here, Amazon, and Intel all at an intersection, and have interoperability with qualified nursing or something like that. Have even a more private area you can come to on your lunch break or 10 o'clock, and one moment someone's talking with University of Washington, the next it's Virginia Mason, it's Silver Lake, it's multi-care.
Yeah.
Could that be possible for access?
I have a question from the public here.
I'm David Luxon with DSHS, Fire Department of Defense. I did a lot of work with Telehealth, work with ATA, and I'm defining some of this. An important distinction that I think you should consider is clinically supervised versus unsupervised settings. I think ATA takes that approach, and it just but it's important because your description of home included both clinically supervised and unsupervised settings. I think that can cause some confusion. So I think you have to. I think it should be open to clinically unsupervised settings as long as you've taken the steps to assure privacy and safety and those kinds of issues. I'm a proponent of broad definition because I do the active duty service members in a library, like a private room in a library. So keep it broad. Consider that supervised versus unsupervised.
And so you're saying unsupervised versus supervised is not all that relevant?
It is relevant because if you don't have a clinically supervised setting, like if you're doing it to a home or you got someone in an RV and they're on some campsite with that Wi-Fi, and they have a medical emergency during your session, well, then what? So you don't have staff on site, so you have to be thinking about that safety plan. But I just think it's an important thing to include in the discussion because you've got tons of places where you can do telehealth, but they're not going to be clinically supervised, so you have to take those steps to make sure you're as safe as you would in a clinically supervised setting, or at least taking those types of steps you need to do to assure some level of safety and emergency.
I have a question. So is the goal to list out all of the setting types or try to define what home means? Is that what?
That's not my goal.
Oh, okay.
I mean, I think I'd like to have to make some recommendations as a collaborative as to some of the principles of security, privacy, and that they should be mutually agreed upon by the physician and the patient. But I think by specifying it out, you're always going to have some exception.
Right.
And that's why, Cheryl, I mean, I think that list is great to have as examples.
I agree.
And I'm glad that you're thinking about patients who don't have homes, traditional homes. But there's always going to be the exception. I mean, I personally have done a telemedicine visit as a patient from my workplace, and it was fine. I think that's probably the most common example is the workplace. So as long as we make recommendations for this as secure and as private as possible, that it should be left to the discretion of the provider and the patient. That would be my personal hope. I'm getting a lot of head nodding here.
Absolutely.
Yeah.
I think if we try and get too narrow in our approach or definition, or these are what we described as home, we're looking at the challenge with the reimbursement, but we're also looking at the challenge with the millennials or even the next generation after the millennials that could care less as to who hears this. For all they care, this video visit could occur on Facebook and they would still be fine, which isn't comfortable for any of us, but it may be their space of comfort. So I'm cautious to not pigeonhole us into such a secure environment that they don't want to access these services because it's so narrowly defined.
I really liked your point because the telehealth model that I function in is actually in a very clinically supervised setting on the peninsula where people check into a clinic and there's a telepresenter. And so maybe broadly defining that it could be in either a clinically supervised or unsupervised setting, but that privacy, however we define that, is upheld. Because even in my clinic setting, how does that patient know on the Olympic Peninsula that I don't have the door open and that someone can be walking by and hear or see it? So how do we kind of throw those broad strokes out that imply that not only there's some universality in the setting in which it's going to be seen, but also that privacy needs to be protected, whether that's pulling a blind down. I personally see patients in my office. My equipment, my computer is equipped, but people will still come up and look inside the window because there's a little crack that doesn't have shaded glass. So I put a big piece of paper up, and then I put a big note on the outside that says, telehealth session But how do we make it implicit that those measures need to be identified and upheld?
I think you raised a really good point, is that privacy is a two-way street. Privacy on patient side and the provider side.
And the guidelines I know that I'm familiar with do have recommendations as to what should the provider's milieu look like? What should that be, and how private? How do you take the steps to ensure that privacy? And then how also do you try to do your best to ensure that the patient is in an environment that's safe and private, and then don't have a spouse or somebody listening, and that makes it not safe for them, and that inhibits what they can say and talk about. So I think some of those types of questions up front are sort of instilled in some of these guidelines to try to, as best one can, make sure that the environment is safe and secure on both sides.
Preserves confidentiality, but also promotes their ability to be forthcoming.
I want to ask some questions of our providers who are on the panel. So Dr. Jones and Dr. Jimenez, do you have any comments or concerns about this definition of home as we're discussing it?
I'll go first. I certainly agree with the more broad definition. I mean, I think in my book, you kind of already hit on the definition of a private, secure, confidential environment is, for me, a reasonable definition of home.
Yeah. Thanks, Jeff.
Yeah, I agree. I don't have a specific anything to add to what is being said. I am actually looking forward to the consultative models. I think it's one of the goals to have provider consultative models, another type of the standard encounter of this project, how according to guidelines. That's what I'm looking for. Perhaps if we move towards understanding what goes into that telehealth encounter with a patient, then we can say this is the standard model. It usually happens in a clinical setting, from clinical setting to clinical setting, provided in the University of Washington, for instance, and myself with a patient in my clinical location. That it's and everything that goes along with it. Perhaps that's what I'm looking for. And then moving towards the another setting, the home, the homeless situation, the car, and so forth. But privacy, I agree again. Privacy should govern all these direction that we take.
Any other questions from phones?
So this is Randy again, and I just keep thinking of some of my time as an administrator, and I again worry about the liabilities for the providers. When it's somebody's in a home and there's people around, or they have friends over, and the provider is not aware of that, and then the friend goes out and says, "Oh, I just overheard the conversation with the with the doctor and Henry, and I didn't know this about Henry," and then who has that liability, and how does that need to be addressed?
Yeah, great question.
To a certain extent, we see that in our regular practices in person, though, as well, is they bring, not just their husband or their son or daughter, they bring the son's friend and, 3 or 4 people in with them occasionally, not often, but that's very comfortable. You have to make sure they feel safe, and how many people can we get to?
But in the class setting, you don't always know who's in your shot, right?
Yeah, that's more the challenge is identifying who's in your shot.
I think along those lines, I agree with your definition of home, which is reinforcing the guidelines and principles of privacy and safety. I want to make sure we don't set too high a bar, though, that's unreachable. My practice is as a hospitalist, and I've yet to work in a hospital where there isn't a common room. And we talk with patients about very life-changing issues that are only a small curtain away from the person next door.
Sure.
That's standard. That's quite common. And so I think you want to aim for it. You don't want to let go of that. But I think if you set this bar that's absolutely private and secure, where it's somehow invalid, that's not realistic. But I like the idea that it's mutually agreed upon for the provider and patients, and there's trust involved in that. And I think if we put that as the goal, that's sufficient. The one part of geography I have wondered about in matters is, does it need to be in Washington State?
Does that have to be in Washington State? I think that there's quite a bit of clarity on that, Chris, is that the patient needs to be physically located in Washington State. Yeah. So, your long-term patient who's on vacation in Hawaii,
Right.
technically you need to be licensed in the state of Hawaii to be there. Whereas, conversely, if you have a new patient who is from California, you've never seen them before, but they've got strep throat or UTI, since they're located here, we just look at the other thing. So it's where the patient is at the time of consultation. That's pretty clear. Yeah. Corey.
And I don't know if this is helpful or not, but for a lot of our programs, we develop marketing materials for the patients or web materials that clearly identify the criteria for who is appropriate for a visit, the environment that would be required, where you have to be geographically. So we just kind of state all that up front, and people might, not necessarily be truthful 100% of the time, but that's as much as we can do to ensure what we would like.
Would you be willing to share that with the group?
I'm sure we're kind of developing it,
Okay.
so we're not process.
Yeah, one of the things that Sheila and I were talking about beforehand was, and it gets back to this definition of home, is, if you've never seen a patient before, how do you verify that this really is the patient? So we've talked about privacy. I think the other kind of concern, and we'll talk about this more, is fraud prevention. And there's fraud prevention in a variety of ways. One is that the patient is misrepresenting who they are, trying to get the benefits of this. The thing I think most people think about fraud prevention is doctors billing for ghost patients, making out patients. So that's we'll get into this more, I think, in subsequent conversations, but just to kind of introduce that this home definition does touch that area.
I know our clinics have experienced that in person. People have tried to use other people's information to get into the
clinic. Right.
There's consent as well.
There's consent.
There's a way to get consent. Everyone's consent to be physically obeyed.
So one question might be, how does this connect to opioids, benzodiazepines, and other DEA type meds?
Well, we can talk about benzos because there's a federal bill called the Ryan Hate Act that explicitly forbids prescribing of benzos through telemedicine. So that's my understanding, right, Cara?
In person.
Yeah, you have to see them in person, and I think it's pretty similar with opioids. I'll just tell you what UW and has done is that we do not do any kind of prescribing of benzos or opioids through telemedicine. It has to be all in person, and that's true of Karina. Karina, there was
it was not zero.
Yeah. So
another question would be, are we going to look at what can be pre-recorded? So a physician with a hand is trying to show another physician, orthopedic physician, this hand, but doesn't necessarily need to have it live, but having the visual along with the story and a physician or a nurse asking questions and then pre-recording this, sending it as a packet. We're doing the live visits now, and that requires a lot of coordination to get access right. People need to show up to make good use of everyone's time before FIDS. Or a mom leaving for school, you got a rash. Is it the beginning of a MRSA lesion? I just want to show this to you. We're covering it up, going to school, but I'm sending you this now. Could that be a pre-recorded thing? They might call back and ask for another set of questions and things like that. But could that be a composite visit that makes a visit?
So I think that's called out in Senate Bill 6519 under what's called store and forward language. And maybe I think it's a great question, Scott. Maybe we can table that for another time. But I think that there is some language on that. So maybe can I summarize what we've talked about so far? So I think the recommendations to that we'll report back onto is that there's that we recommend that doctor to patient or clinician to patient visits be as secure, as private, and as confidential as possible, and that is mutually agreed upon by the clinician and the patient. So that's like a principle that we're trying to illustrate. However, that we favor having as expansive a definition of home as possible, and that would be basically agreed upon through the patient and the doctor. Okay.
I think somebody, this is Ricardo, John. Somebody, I heard somebody was suggesting also sealing that, understanding that agreement with a consent, the standard consent, that it's a consensual encounter. Somebody mentioned also, I cannot see what's on the other side, but if the patient agrees through a consent, the standard consent, then I think that we'll be fine.
Yeah. I'll just tell you what our attorneys have told us about consents is that telemedicine is not a procedure per se. It's not anything like that. So they have advised us you don't need any kind of special consent for telemedicine. It's like any kind of other kind of delivery of care. Now, obviously, for any initial visit, you need to have a consent to care. But telemedicine per se, spelled out, has not been something that we've said we need to have a special consent for.
As continuity of care.
As a continuity of care.
Yeah, and I was more referring to an initial visit.
Yeah.
These are all
Well, I'm gonna type this up as well, and we'll send this around for people to get full comments on definition of home. But are people comfortable wrapping up our conversation about that? Senator Becker, do you feel like we address this adequately?
Sorry, I had to unmute. I am really comfortable with the conversation. I don't know that I'm comfortable that enough that we have without, if you put it in writing so we can take a look at it and say, have we done our due diligence and bring that back to the next meeting.
Okay. Good. And we don't have Adam Romney here, who's our attorney at Davis Wright Tremaine. So it'd be good for him to work at this as well.
Okay, thank you.
Great, thank you. Well, good.
But I think a great conversation. I've been taking notes, and one thing that I think is really critical that you all hit upon was the no opioids over telemedicine. I think that is a really strong statement to put in the next piece of legislation moving forward.
And do you want to say a little bit more about that, Senator Becker? That are you advocating that telemedicine not be used for treating patients with opioids, or what's? Well,
the problem that I have is right now opioids are. I mean, it's a nationwide epidemic, and there's task forces working on it, et cetera. And I would really have a concern with prescribing opioids, except for maybe in a follow-up visit. Like my husband just had a total knee replacement. And maybe he would need, if they were giving out a very small amount at the beginning, maybe they could, but he'd still have to pick up the script, correct?
Yes.
So logistically, it would be the same as an in-person visit.
Call it in.
The other question though about the other side of the opioid issue is just that the lack of capacity of MAT programs or Suboxone providers, and as we talk about the prescribing side, the initiation side or continuity side of opiates, that's one side of it. But the other side of it is, could we not use this as a really strong vehicle to really work on the addiction side, or the side where we're just really trying to mitigate what's sort of been done. So as a way to kind of monitor patients who should be on or could be or are on Suboxone and that sort of thing. I could see real value in the strength of telemedicine.
So this is where I see it, and this is Randy again, where I see it as we create the center of excellence, and this is a continuous conversation with a lot of these issues, but not necessarily resolved in one piece of legislation moving forward.
And this is Joelle. I, as a prescriber for almost 20 years, and understanding our national issue with opioids, certainly understand where we're at and the importance that we all identify this. However, in my current clinical practice, one of the populations that we see are folks with cancer who are status post in esophagectomy, major procedures. And these people are often 60 years and older who have no business getting on the road and traveling after a big surgery, 6 hours round trip to see us for a 15-minute post-operative visit. And so, but their post-operative pain can last 6, 8, 12 weeks easily, given the extent of the procedure that we did on them. So, caution in eliminating patient populations who have chronic, ongoing, or acute issues, and that we don't squash those opportunities and limit people's practices and force people to be coming to major medical centers or otherwise unnecessarily, which I think is the whole point. One of the elements and benefits of telehealth capability.
A lot of these examples, though, are also in a continuity. I mean, you're going to have a surgeon that would be the same surgeon following your post-op care. It's a second, third, fourth visit. I think where we should probably focus our efforts on this issue would be primary visit, first visit with this entity, whatever this virtual health entity is. Don't know this person from Adam, don't have any records on them. Should we be prescribing opioids for anything in that case? Because it's a virtual visit. We've never actually laid hands on them and validated, had the opportunity to validate any of their other background that they're telling us.
So this is Ricardo. As we struggle with this issue, even to respond to the epidemic, we are strategizing. It is a very difficult situation. My comment will be that we will stay away from the prescribing of opioid benzos through this service. I do hear that cancer and terminally ill patients, I do hear that argument, but the overall issue of this prescribing and the consequences, I think it justifies and encourages to look at the PCP and patient relationship at the basis of any prescribing activity for these patients. I don't think at this moment we should be using this service or this way of providing service to that scope of practice. My comment would be not to stay away from that.
Right. Well, I think that's a session on its own, talking about opioids. I mean, that's opening a can of worms there, but this does illustrate how telemedicine touches a lot of different things. I want to spend maybe the next 20, 25 minutes talking about reimbursement, since that's coming up in January. And I just had a lot of questions from physicians as to, I mean, really, I think it was a question last time, is that, are we actually going to get paid? And so I wanted to, in particular, talk to the insurance companies who are representing on this group, and kind of, if you could share whether you have policies that are out, if you have some recommendations or guidelines that you can share with doctors on how to submit claims, what's the best practices, even getting down to CPT codes that people should be using. I think we're really looking for you all to give us a little bit of guidance on maybe the mechanics of reimbursement starting in January. So I'm going to look to Brody and Cheryl and to some extent Francis and Chris. Do you guys have any things you could share with us?
So I don't have it memorized, but we do have a public-facing website that does indicate which codes to bill and which modifiers and things that apply in those cases. So, I mean, it is fully in our intent to cover a televisit. Most of the focus that I have right now are the primary care type of visits that take the place of an urgent care visit or things like that. I do know that there are policies out there about telemedicine visits, of doctor to doctor with a patient there as well. But we do have a public-facing policy and a reimbursement kind of like a tip sheet or whatever you want to call it. And I could definitely send it to you, and you could distribute it to the group.
And I know Regents has got a multi-state reach, and there's probably some states where they're already being doctors are being reimbursed. Any kind of do's and don'ts that you can share with us that maybe in other states that that kind of learned?
Well, our policy is the same in all the states that we're in. So there's really, I know that each state has different expectation regulation, but as far as our reimbursement policy, it's consistent. When I send the actual link, I'm happy to send over any of those tips that the reimbursement folks.
But I just think it'd be time-based billing, essentially. You can't really do a comprehensive physical exam for these hormones.
Yeah, so there are different codes that generally are based on time and other things as well. So.
Cheryl?
Yeah, we have public policy as well that I can send over to you. So you mentioned the modifier, and I think the modifier is when it's a patient in the office with the provider contacting another provider. And then I think there are separate CPT codes for the actual telehealth visit when the members on their own.
Oh, okay.
So
yeah, so they tend to be time-based for phone, and then there's like this level 4 that includes video. And so it comes down to that level as well. So if there's a video aspect to it, there's one code. If it's phone-based, it's generally time-based.
So this is Randy again. So on the modifiers and your CPT codes and your diagnosis codes, et cetera, are these indicated in the CPT books at this point in time, or are these internal?
they're in the CPT books.
They're in the CPT books.
I don't recall them off the top of my head.
So ICD-10 or CPT?
CPTs, they're like 99 something
I
codes.
want to say 4.4, but I'm not. Yeah, there's actually CPT books. They're codes for telehealth.
So I think we use a GT modifier that identifies it as a remote encounter.
That's what we used.
So I think if I remember right, I think the GT is if a patient's in with the provider and they're calling another provider. That's when we use.
Yeah, this is in the medical center with a telepresenter, not necessarily another provider, but under the umbrella of an established entity that has a tax ID that's identified as a rural setting.
And the patient is at the center.
They're in a clinic.
Mm-hmm.
Yeah, with a telehealth card.
Mm-hmm. Yeah, so I think there's a difference in billing between that and if they're at a remote site on their own telehealth visit.
That'd be great if we could get some clarity on that. So I've been told by our billers that we need 3 things in order to drop a bill. The first is that it needs to be specified as a telemedicine visit. So if you're a nephrologist, it needs to say nephrology, outpatient, telemedicine visit. That's one thing. And that might be just unique to our system. The second is that there needs to be the proper coding in the CPT and GT. And the third is that somewhere in the note, we need to say this was a live face-to-face video teleconsultation. We've been told that we need to have that line somewhere. Is that true?
Yeah, we have a statement in Swedish that we use that says this is a live face-to-face encounter via encrypted video audio conferencing.
I wonder if that's for documentation for audit purposes or something? Because
it's not from your perspective.
It might. Well, maybe it's documentation to document the code that was used.
Yeah.
But I can't think of what.
But I think that it just confirms and identifies it as a telehealth encounter versus an other.
So we use the standard HCA fee schedule. So we use the CPT codes that are identified by HCA standard E&M codes, and then we just basically they do come across currently with a modifier. Though I would like to revisit that, to be sure that we want to be more specific as we get more broad in terms of this. Right now, there's the urgent care visits primarily, but that's what I have to do. Standard codes. Also, we use the standard telephone codes. It's also based on time. It's all time-based, both for live video and also for telephonic. We're not doing star and phone yet, but we need to figure out how to do that as well.
So maybe as an action item, I can ask to clarify on the GT, like what that refers to. My understanding is that we don't get paid for phone visits. It's specific in the legislation. It really makes a distinction between telemedicine and email and phone. And email and phone are not reimbursed. So I'm interested that you guys even are
Well,
keeping track of that.
I get paid for telephone.
yeah, no, we do get,
visits.
telephone is not considered telemedicine by the state definition, it's really true.
Right.
But there are phone codes that you can actually, physicians can develop, that are reimbursable. And again, it's based on time. And so, and the documentation and everything is the same expectation. And quite frankly, all the telemedicine provider, commercial providers, that's how a lot of patients are getting it. We think of our, Medicaid membership. I mean, a lot of them do have smartphones, obviously nicer than my phone, But I would also say that a lot are using landlines and other, vehicles to get in. So we wanted to keep the bar so low and not, let lose anybody and make sure that they could reach us. And so we had to find some way to communicate that. And so we went to the state, and HCA was great about supporting a pilot. Now the pilot's a program, but they're all codes that are HCA published.
So both Premier and Regents are reimbursing for phone on time. And does it have to be over 10 minutes or so, a certain amount of time, or?
Those are about 22 minutes.
So the different codes.
Is there a threshold of time on the phone for which you will get paid? Or, it's 5 minutes.
It's not like the 99406, 407 that's based on 3 to 10 minutes or greater than 10. It's actually broken into 15 minutes, and there's like 5 minutes.
Okay.
And if I may ask Sheila, are those reimbursed then at the same RVUs as the office visit in person?
Absolutely not.
Cheryl?
They have their own reimbursement.
Yeah, they have their own reimbursement.
It's low reimbursement.
Yeah. I mean, I think that sometimes the juice isn't worth the squeeze.
But it demonstrates that we're doing the work, and it puts it on the radar, and I think that's important as we transition our care delivery models, and if we want to leverage reimbursement down the road. We can demonstrate that that's a common modality of care delivery.
So there may be an important distinction in the way that the question was asked, though, as far as the RVUs are not set by the insurance companies, right? We can change the way that policies work, things like that, but the actual way that the payment is made is that the RVU for that code, if the question was, is it the same as for an office visit, the answer to that is no, but the RVU itself that was set is also different than the RVU set for an office visit. So I just want to make, because I wasn't really sure where the question was narrowing in on, but the bottom line is that the RVU is lower, therefore the reimbursement is lower.
Maybe I'll be really clear here. So I'm a doc, and I spend 15 minutes talking to you on phone. How much do I get paid versus 15 minutes of seeing you in my office? My understanding is that office visit is that time's going to count more than being on the phone.
So I speak that's true. And so the way that the payment is made is that there's a conversion factor rate of whatever that is, and you multiply that against the RVU to get the payment. So the relative value unit that was set for the code for the phone is lower than the relative value unit for the office visit. But that's how the RVU was set. It's not that there's a difference in.
And that's the worker
conversion factor.
That's the physician component, or the provider component. It certainly makes sense that the overall RVU with the overhead of the office and that type of thing would be lower, but the provider piece of the RVU is
that component. I'm not.
Yeah, it is lower, but think about it. I mean, we're not laying hands on the patient. It's often we can manage a telephonic engagement because we're not doing a comprehensive review of systems and a physical exam. So it makes sense that it's a lower RVU, and it's often a quick follow-up.
It wouldn't necessarily have to be from your office. So I was just looking up, the 99441 is the lowest one, and it's 5 to 10 minutes of discussion, so less than 5.
Yeah, and we need 99442, which is 11 to 20, and then 21 to 31.
So we just, so the problem is we have, I think, the same stuff. We've got the CPT codes. I also don't have them memorized. But we're crafting, because we have, as common case, we're a little bit different. So we have to also craft messaging to our own provider group. It's good using these things and billing differently to our own insurance plan. So we're doing both sides. We're crafting the infrastructure and the how to be used internally, but easily be externally facing as well. So I can share those.
Great, thanks.
So I have another question. I'm probably going to have to call and talk to Sheila and Regents, et cetera. But, you know, when we're talking about utilizing follow-up care for procedures for those folks that are, you know, in rural area, et cetera, usually there's a global period for that. Would you pay for teleservices, you know, the conversations, if they're done by telemedicine for within that global period?
Well, currently in the postoperative 90-day global, we do not bill. We use a 9903V, which is that
right
up, and then but we still identify it with a GT modifier because we're obligated to, you know, to the, I guess, the powers that be, so that they know that this was conducted via audio video conferencing. But that's actually one of the benefits. Again, I mean, postoperative care often can be comprehensive in terms of management, constipation, pain, diet, and a quick wound check. But you know, when you consider the overhead and the cost, which is about $100 round trip from the Olympic Medical Center, it ends up being a cost savings for people all the way around. So people sure appreciate it, but yeah, we don't bill for it.
Cheryl and Brody, do you know anything about the global period?
No.
Jot it down.
Yeah. So, and I know that Senator Becker, there were recent changes in CMS language about the global period in telemedicine, and particularly around the total joint replacements.
Mm-hmm.
That telemedicine is an approved modality, and you don't need to, you don't have all the normal restrictions that Medicare throws out there, like the rurality requirement and the patient needs to be in a doctor's office. They kind of did away with those requirements for telemedicine. So I know at least under Medicare that those are in the global periods for total joints, it's a little more flexible, which is great. I think what Medicare is trying to do is do these little pilots to see what the uptake of telemedicine can be without really opening it up, you know, removing all these restrictions they've had in the past.
All right, thank you for that update.
Yeah. Well, good. Well, this is really helpful. I think we got a couple follow-up items, and I appreciate people sharing their policies and sharing any kind of recommendations for patients. I'm going to spend the last 5 minutes just doing some logistics, and that has to do with planning our next meetings. And I think in our last meeting we had expressed a desire to get at least one meeting over on the east side of the state. And I know that Joel, your colleague in Spokane, wasn't able to join us, but Denny said he'd be willing to host the next session at Providence in Spokane. And we're just trying to nail down a time in October. And maybe if we can move it back to somewhere on the west side of the state for either November, December. Can people let me know if there's any no-go times in November, early December, because we do need to finally have a final report out by the end of this year. Maybe I start with Senator Becker. I know that there are some restrictions on your schedule based on when the session starts and the like. Senator Becker, I don't know if you have your calendar in front of you. So if you don't, that's okay. We can get it offline. But if you do know certain no-go dates, it's good to hear those right now.
Okay, I think I can give you a couple because we've sure been trying to get a handle on them. We have the House is in reorg on the 29th and 30th.
Of October?
This is November.
November, okay, so late November.
And we have assembly days on November 14th and 15th in reorg. So that's when the entire all the legislators will be there. I can't talk today. In October, my schedule is kind of a mess because it's election time and it's just filling up. And then of course with my husband's surgery, but I don't know what to tell you about no-go days there at this point.
Okay. Well, we'll do our best to work around the dates in October, and I appreciate that's still like next week.
Yeah.
So it might be later October that we're looking at. And Senator Becker, when is Election Day again? It's November
8th.
Yeah.
Yeah.
That first week of November just totally out for you?
Totally out. I know I'm I can give you some good dates, but the physical therapy may blow this away. But the 17th, 18th, 21st, right now on my calendars are open.
And this is October?
Yes.
Okay.
Yeah.
Thank you. So I imagine we'll have somewhat of an overlap with Representative Schmick and Bergquist and Senator Cleveland, knowing those. So I just wanted to make a general announcement about hosting. We're trying to move the hosting around to members of the collaborative. The requirements are just to have a room size of about this size. And I know some people were concerned about using Zoom. I would say that if we can do any kind of a phone option, that would be sufficient. And we can just, if you have a phone line, or we can even use the phone line that we have. But don't feel like you need to have a big fancy system like Julie had down in.
I was going to say, we can use Jackson Hall, that same space that we first met in.
That was a really good space.
At any future date, if we don't have any.
I think Zoom was the limiting factor.
Right, and that's why I just say, if you have a big enough room, we'll use phone.
We have a really nice.
And Chris,
it was the Zoom.
Okay.
Factor, so
Okay.
you can alleviate that.
Great.
Probably find space.
So I might look to one of you two to host either the November or early December.
I would say at Swedish, we're looking at some major construction projects, and conferencing rooms are going to narrow considerably after the first of the year. So,
so the earlier
we want
the
to
better.
capitalize on this hosting. We should. So then maybe reach out to Jennifer.
I think that we already discussed that, and I think she was going to hold me a room in October.
Awesome.
Yeah.
Although we might be East in October.
Oh, JK.
Yeah.
Just kidding. Okay. November?
So stay tuned. Hopefully we can get Jeff and Denny in person next time. So great. So then I think that's all I had. I wanted to open it up for public comment, public questions for the last 5 minutes. If there's anyone from the public who would like to identify themselves and a brief comment, that'd be great.
I'll start off over here. I'm Emily Yu. I'm the program manager of virtual health for Multi-Care Health System. And I think I have to echo the questions and the ongoing questions around what reimbursement is coming January 1, 2017. So the line that really sticks with me from the legislation is that all care that would normally be reimbursed for in person is mandated to be reimbursed on January 1, 2016 with the list of originating sites. And so I have reviewed the region's telemedicine policy that was approved for April 2017, and my question to the tier side is, how are you anticipating to incorporate the wide variety of medicine that might happen, or even diabetes intervention that we do at Multi-Care that will occur over telemedicine with just a set for code based off of phone visits?
Thanks, Ellen. Any other comments, questions from the board? Sean from WISMA. Sean, do you have any? Are there folks from DOH? Do you have any things you want to say?
Actually,
Yeah.
I'm Dave Loiston again, DSHS. As you work towards anything related to legislation, policy stuff, I'm sure they just had an interesting for the Department of Health and everyone on that, because we have particular things of interest for our population, and we're specifically going to have some stuff there to telehealth. We'd love to be able to input into that, if that's part of the objective of this is to put up produce legislation. So,
Great, thank you.
On the heels of that, if I can just, my name is Dan Stone, I'm with Assured Events, we're actually a telehealth remote patient monitoring medication management provider. My only question, or I guess encouragement, would be as a group of providers themselves, if you have questions and basically technology-specific questions, there are resources out there that can help answer a lot of the questions that were asked. Great. Thank you.
All right. Any last questions, comments? Good. Any last announcements? Do you have anything? Okay, good.
ITRC conference.
Yeah. Okay, thanks everyone. We'll be in touch. I'll grab that first.